Yeah.
Not hearing anything? I know it's not on yet, but look at this, turn up the volume.
I don't know if it's okay.
What do you say?
No, I don't know, John Carlos is not coming.
Oh, nice, that'd be nice.
No, he probably, I mean, I don't think they get any CDs.
Definitely
We hear it.
find it. No, how do I turn up, is the volume on? How do I know if the volume's on? We need the microphone. Where are we looking? Oh.
Great. Welcome, everyone. I'm pleased to welcome today our final global speaker of this series for this academic year. We will be back next academic year, so look out for that. Our Global Local Center for Mental Health Disparities has been hosting this Global Minds, Local Insights Mental Health Research Scholar Series. We've been very fortunate. We've been very fortunate to have a number of speakers from around the world, starting from South Africa and looping back around again to South Africa after having speakers from Kenya, Peru, and Liberia. This series has been brought to our group by the support of the Peter H. Knapp Fund, with the devotion of bringing lectures in research to the field in the field of psychiatry to our Boston University School of Medicine Department of Psychiatry. So we're very thankful for the family of Peter Knapp, who's provided this fund through the Boston University Giovanni and Advisian School of Medicine. Today, I'm delighted to present Dr. Laila Asmal, who is the Associate Professor and Clinician Scientist who heads the Psychosis Research Unit at Stellenbosch University in Cape Town, South Africa. She's an associate professor, as mentioned, and earned her PhD in examining neuroimaging and schizophrenia in first episode schizophrenia in South Africa. She also earned her medical degree at the University of Cape Town in South Africa and an MSc in clinical epidemiology. Her work examines childhood trauma and neuroimaging and psychosis, which has helped to develop her special interest in the biological, behavioral, and environmental factors contributing to psychosis risk and recovery in Africa. She's an experienced neuropsychiatrist and is passionate about raising awareness of the relative neglect of psychosis in the global health agenda. Her vision is a collaborative network of African centers on psychosis research. It's my pleasure to introduce Dr. Laila Asmal.
Thank you, Maria. It's always Lovely to start off by hearing some nice things about yourself. So thank you. And thank you for attending this this afternoon. Here we go. So it's always a bit tricky to decide what to talk on when you have infinite possibilities, when they say, speak on anything you like. All right. But this has been an area of interest that I've been developing myself and our team over the past few years. Started off looking at the general environment in Africa, and then we looked specifically at trauma. And over time, it became very clear that the environmental risks on the continent are complex. And I'd like to unpack, in particular, the urban risks that are associated with psychosis. I've got no conflict of interest or financial disclosures to declare. So this is where I come from. How lovely is that? This is Cape Town, South Africa. Has anybody been? So this is not a Photoshop. You can confirm that. So it's really a stunning and diverse landscape. This is Table Mountain, which on certain days will have clouds over it, and then it's said to have a tablecloth. This is Lion's Head, and if you kind of squint your eyes, you will think that this is the mane and this is the rump, but we don't call it the rump or the bum, we call it Signal Hill. It's a great area to hike on. Table Mountain has been described as, well, it's actually been officially classified as one of the new 7 wonders of the world. This is a very rich area of Cape Town, the Atlantic seaboard, the Atlantic Ocean. This is a World Cup stadium that looks like something that a baby would potty train on. This is our central business district. There's some very fancy houses over here. I don't know what accent that was. There's some very fancy houses over here as well. And Cape Town stretches all the way down to here. This is my husband's a kind of an amateur photographer, and this is Lion's Head again, and this is a beautiful kind of like fog coming over the mountain. So it's a stunning, stunning city to live in for me, but for others, about 20% of the population live in informal settlements in Cape Town. So during apartheid, about 60,000 non-white families were forcibly removed from areas designated for white residents and made to live in areas generally quite far from the city center, and that spatial segregation still continues. And part of that is geographical segregation. The mountain and the ocean segregates, it limits how the city can grow. So this beautiful city kind of enforces geographical segregation. We all know the Gini coefficient, which is a measure of income inequality with 0 indicating perfect equality. So the closer a country is to 0, the less equal, the more equal it is, and the closer you are to 1, the more unequal it is. And so South Africa has a Gini coefficient of around 0.63. You don't want to go above 0.3. So we're pretty high, amongst one of the highest in the world. Unemployment rate in Cape Town across the board is about 21%, fleet unemployment, but in the townships, it's around 30% or more. Access to services can vary, and so this is how it goes. In the high income areas, the pretty slides you saw originally, you know, everyone has jobs, everyone has access to services, private healthcare spending, which is how you kind of spend money in high income areas, is about 20,000 rand. What is that? $1,000 an annum is kind of allocated versus in the public sector, it's about $150 an annum. So it's a huge disparity. School qualities, there's a huge disparity. classrooms of about 20 to 1, 20 kids to 1 educator in higher income areas, 40 to 50 to 1 in the lower income. Infant mortality is much higher, about 3 times higher in the poorer areas. So there's a huge, the income inequality is reflected in, like in many countries, as you know, when there's income inequality, there's healthcare inequality and other outcome inequalities. So, so this is the township. The houses are made from whatever people can find. This is called the shack in our language. These toilets that are often provided by the city. But you can just imagine the state of the toilets when it's shared, and the toilets themselves come with risks. It's a very violent city, so you need to go to the toilet in the middle of the night. It's not the safest place. Because of space shortages, there's areas that are designated okay to build informal settlements by the city, and there's certain services that's provided, including electricity, but those places are full up, so people build in places where they shouldn't, like the floodplains. You can just imagine what happens every rainy season. So, actually, I haven't started my talk yet. So, what am I going to talk about? I'm going to talk a little bit about schizophrenia risk in the urban environment generally. And then we're going to look a little bit deeper. Why is urbanization risky? So what is it about the urban setting that kind of makes a person at risk? And then we're going to talk specifically about rapidly expanding urban settlements, because I think that that's in particular relevant to Africa. So let's start by talking about the urban environment and psychosis risk. So I did a lot of reading for this talk, some of it necessary, some of it unnecessary, which is really interesting. And I think I'll remember one fact. And if you're going to remember one fact from this talk, remember this, and it has absolutely nothing to do with psychosis. And that fact was from a review article on urbanicity and health that said that we can find systemic health benefits for living in an urban area for all the systems of the body. You know, there's drawbacks to your GI system for living in an urban area, but you can find a positive: skin, gastric, renal, whatever, for every system in the body except the brain, except the mind. So there are no benefits. I found this really alarming because I live in an urban environment and I live in a very nice, my little bubble is a very nice one, but there's no benefits. If I could mirror my life in a less urban space, it would be more beneficial. So, wow, I found that very alarming. Maybe it's just me. So back to schizophrenia. So schizophrenia and prevalence. How many of you here are clinicians? A large part of the room, and have kind of researchers. So clinician plus researchers. Are you all familiar with schizophrenia, those that are here? So, I mean, the prevalence, the kind of prevalence that everybody talks about is schizophrenia is seen all over the world, and it's roughly 1% of the population. But there's a common misconception that rates are consistent between countries and within populations. So people will say there's no difference between America, the US, and England, and everywhere in the US is the same, and that's a misconception. The problem with our prevalence data, I mean, there's many problems, but one of it specific to Africa is that data from the least developed countries tend to have the greatest data limitations. And if you think about it, it's obvious why that would be. But there has been this historical story and narrative that people from low-income countries who live in rural areas and they're protected by this communal love that's there and protects them from mental health problems. There's been lots of challenges to that, but one of the biggest issues is that we don't have the data. So this was a really great review article looking at incidence, prevalence, and global burden of schizophrenia across the world. And it looked at incident prevalence and burden, but I'm going to highlight the age standardized incidence rates of schizophrenia. And they specifically looked at the year 2019. And across the world, it was about 16.3 per 100,000. That means that for every 100,000 individuals, around 16 new cases of schizophrenia were identified in the year 2019. Yeah, pretty straightforward. However, there are significant regional differences, as you can see quite clearly. Some areas we're looking at less than 13, the whole of Africa, how lucky are we? And then some more than 22. Oh, that's not looking so good. And so the high income regions, high incidence rates are reported there, particularly in the US and Western Europe. But the higher rates can be attributed to better mental health infrastructure as well. So systemic data collection and reporting practices. Any of you know about the Nordic countries and how they collect data? Oh my gosh, it's like next level. They're not missing anything. Surely that counts. In low-income countries, I mean, with the one Liberian psychiatrist that was there, Dave, until fairly recently, how are you catching all the cases of schizophrenia and logging it, so there's that. So trends over time, so it might be a reflection of how data is captured rather than the actual incidence. But trends over time is that across the world, the incidence of schizophrenia is increasing. Again, is that because we're getting better at capturing data. So one thing that's very clear is that there's been an increase in incident cases in sub-Saharan Africa. In the past 20, 30 years, we're looking at about 130% increase, specifically Central and West Africa. But the prevalence studies, the rates kind of so varied between 1% to 4.4. And if you look at it, part of it is because these are the only countries in the whole of Africa that have had any kind of prevalence studies. So South Africa, as usual, is overrepresented, but I don't know, a few prevalence studies. Then in Burkina Faso, Egypt sometimes doesn't even call themselves Africa. Ethiopia, Kenya, Nigeria, South Africa, Mozambique, and those huge segments that are just not even represented. So next thing I want to talk a little bit about is the adaptation, and I think this is super important. I know I said that there's one thing you remember, but there's two things you remember. It's this, and this is, I think we've started to think about schizophrenia as a neurodevelopmental disorder, and it's very much an adaptation to a social context. So genes are important, and the environment is important, and they're not important separately. They work together, and that contributes to an aberrant neurodevelopment. So along the way, this child, some people would say that schizophrenia is end stage of a disorder. By the time someone has schizophrenia, it's kind of, the stuff has already happened. It's the development of it that's super important. So you have this aberrant neurodevelopment in your childhood that may be genetically contributed to by genes, by your environment, obstetric abnormalities, maternal infections, and that leads to this aberrant development that shapes your personality, psychological attributes, how you see the world, a little bit more paranoia in how you see the world, and heightened stress sensitivity. You're bullied in childhood, you're traumatized as a child, you end up having a heightened stress sensitivity. And then there's an acute stress that hits you at 17 or 18. Smoke a lot of cannabis, lick some THC oil, dopamine dysregulation, when you migrate to the city, dopamine dysregulation, psychosis. So it's kind of like a story. I'll make it sound easy, but so in all of that, if we talk about social adaptation and the social context, why is urbanization risky? So the first concept around that is the ideas of, well, there's two concepts. One's around social adversity and marginalization. So urban areas as a whole puts a person at risk of experiencing multiple social adversities and marginalization, regardless of whether you are a minority group or not. But minority ethnic groups have a harder time at it. So they face, and we know this So we know this from other areas outside of schizophrenia, that they face higher discrimination, social exclusion, and economic hardship. So why are ethnic minority groups marginalized? And why are they increased risk? So ethnic minority groups are seriously increased risk of schizophrenia, and I'm going to go into that. It could be because of increased social adversity, discrimination. One thing that I think is under-recognized, but super important, is inferior social status. So how you see yourself in relation to others, how other people, very importantly, see you in relation to themselves, and how they treat you in relation to themselves. These are all contributing factors. Of course, there's this issue of diagnostic bias and overdiagnosis of schizophrenia in ethnic minorities, but even for adjusting to that, still is true. And so they found, I haven't found this, but they have found possibly elevated dopamine in the striatum amongst migrants and ethnic minorities without schizophrenia. So this is from a European study. I think most of the data is from the UK. And here you've got incident rate ratios of psychoses, and broken down all psychosis, specifically schizophrenia, and then the mood disorders and others. And here you can see the African Caribbean have a really high rate of psychosis, especially of schizophrenia. And then Black African, so maybe people from Nigeria and other parts of Africa, Asian, other, mixed, and white doesn't seem to be much of a difference if you're a migrant from other areas of Europe into England. But it is increased slightly. So if you look at psychosis along a continuum, so we talk a little bit about psychotic-like experiences. So people who have heightened dopamine and have psychotic-like experiences without having full-blown schizophrenia can be quite impairing. There's this idea that there's a hypothesized rightward shift in the continuum of psychosis in some minority ethnic groups. So what we have is that psychotic experiences, possibly because of heightened dopamine and stress sensitivity, minority groups have this, and think about it, if you're a migrant coming in, refugee or questionable migration status, or you need to constantly get these visa things renewed, you are in an understandably heightened paranoid state a lot of the time, for good reason. It's a self-protection thing. It's not surprising that your dopamine is going to be slightly up. And there's this thinking that there's a rightward shift towards heightened psychotic experiences and full-blown schizophrenia. There might be, and you just need some extra environmental risk or genetic risk to tip you over. The next thing is around neighborhood ethnic density. And the thinking might be that how the concentration of your ethnic group within a neighborhood may influence the prevalence of psychotic experiences. And there's the protective effect of higher own group density against psychosis. So this is a UK study that looked at probability of psychosis and own group density. So it's all minority groups, and the probability gets higher. The probability gets higher with decreasing ethnic density. In particular, for Black Caribbeans. And then you can see for others as well, the Bangladeshi, the Indian, the Pakistani, but it doesn't seem to make any difference to white British. So, and again, that's a little bit, you can't find cause and effect very clearly. My feeling, and I'm not alone in this, is that it's about inferior social status and how you see yourself amongst others. And I don't think it matters that much if you are white British and you go and live in an area where you are minority, if your place in society is one of that is solid and not inferior, if you know what I mean. That's what some of us think. So this is a great article. This is Jonathan Burns. He was the head of department before Bonga Chiliso gave the first Global Series lecture, and he's now moved to the University of Exeter. And he looked at income inequality and schizophrenia, and looked at schizophrenia incidence for people who related to income inequality of the Gini coefficient. Remember, I said that the lower the Gini coefficient, the better. And you can see that countries with a high Gini coefficient have a higher incidence of schizophrenia. We can look at that specifically more detail later. And then when we talk a little bit more about urbanicity, there's the concept of green space. So the Danes did this fantastic longitudinal population-based study where they found that childhood exposure to natural environments, and it was this kind of like geocoding and kind of assessment of the green space that a person was exposed to in their childhood, reduced the later risk of schizophrenia. And that's, you know, it kind of feeds into the schizophrenia being neurodevelopmental. So the lowest amount of green space was associated with a 1.5 increased risk of schizophrenia compared to high levels of green space. And it was dose response. And this was related or to that relationship existed even after controlling for urbanization, age, sex, and socioeconomic status. So it means like me living in fancy Cape Town with lots of green space, I'm urban, but I'm a different urban from the person in the township, right? So that's one way of looking. The other thing is that could be a really interesting intervention for communities, creating green space as a mental health intervention. But the strongest predictive association was observed during the early childhood years. So you move someone who lives in a nice green area to an urban area later on, and they're a bit more protected than somebody who was brought up in an urban area or was brought up in an urban area and then moved to the rural area. Whether that's related to some kind of environmental or biological insult, infection, or something else, we don't know. So what's the evidence from the United States? I was curious. I went and I looked. Surprisingly, unsurprisingly, limited. But what I found super surprising is that you were at the forefront. And when I mean at the forefront, seriously at the forefront, and then it was kind of zero, but at the forefront. This is from 1939, and I must be mentioned because I don't know, I looked for pictures of Paris and Dunham, but they were epidemiologists, I think, from the late 1800s, early 1900s, that spoke about, the first people that spoke about urbanization, the relationship between social organization, urbanization, and schizophrenia. 1800s. And so difficult to understand as those diagrams were, but in those days. But this is the circle, the inner circle, or the inner zone of your urban environment. And they said that the inner zone tends to be basically the inner city, the most disorganized, and is characterized by isolation, the greatest areas of transition, and with the least community coherence. And as you moved to the outer zones, there was less isolation, the communities were more established, and there was better communication. And they found an inverse relationship between schizophrenia and which zone of the urban environment that you lived in. So this was the first one that I saw. And then there was this amazing person. I think they were a dude because they spoke about, I think his name was Brian Malzberg, 1893 to 1975. He was a statistician working for the New York Health Department. and did all these papers on mental illness and economic value of man and mental illness and immigration. And he described a significant association between immigration and schizophrenia. And I thought this paper, which has antiquated language, was really interesting. They looked at migration and mental disease among African Americans in New York State and found that in this year, a total of 1,403 native-born African Americans were admitted to all institutions for mental disease in New York State. Of this total, only 130 were born in New York State, and the remaining were born elsewhere in the United States. The former, those that were born in New York, had first episode psychosis, hey? 100 years ago. 40 per 100,000. Migratory, we're looking at 186, 4.7 to 1. 100 years ago. This is, I mean, I get chills. I don't know why I get chills. I get chills just looking at it. And then she also get chills. Hannah and Brittany and I were talking about it yesterday, and I said I've got little heart emojis for Jedria Admin. So if anybody's looking to be a fangirl, move away from Taylor Swift and move to Jedria Admin, everyone. So this new, if you're going to read one paper, it should be this one, From Womb to Neighborhood. I think this is an American Journal of Psychiatry a couple of years ago, 2021. It's still kind of like, I think, the gold standard, talking about racial analysis, social determinants of psychosis in the US. It's too beautiful for me to sully with my own words. Just read it and you'll love it. So let's go back for time. Okay. So let's go back to, so I suppose what I'm saying is I think that the foundation is there in the US, and I think that the interest to look at this further, it's right. And I'd love to hear about more studies that are happening in the country. So the last thing I think I want to talk about is the concept of a rapidly expanding urban environment, which is different from, New York City just getting bigger, and Boston's a lot bigger than it was 10 years ago. We are talking about tens of thousands of people coming in and looking for a place to stay in Cape Town with no access to housing or employment or education. So why is African urban health important? Firstly, half of the global population growth in the next 30 years is going to happen in Africa. By 2050, 60% of Africa's population will be in urban areas. It's changing like that. And a significant proportion will be children and adolescents. The pyramid, that whatever population pyramid, it still looks good for us. We have an aging population. There's nowhere like the high income countries. And the children and adolescents, those are people at risk of schizophrenia, right? One thing I want to kind of make clear is the concepts of urban advantage versus urban penalty, because we need to be very clear that there's a huge advantage to moving to an urban area. And it's even greater if you live in a low middle income country. So the answer to this is not to stop urbanization. That's not going to happen. With urbanization comes access to healthcare. If you are living in the sticks and you have HIV, you probably want to move to an urban setting. Better education, employment, and wider social connections. You may not love all these social connections, but if you want to progress, it's going to happen in an urban area, not in the rural area of Malawi. If you want to progress and you want your kids to progress. But the urban penalty that comes with it is unsafe living conditions, poor access to services, high unemployment, and high risk health behavior that inevitably comes with living in an urban area. So in Cape Town, I think we have South Africa is a very traumatized country, and it continues to traumatize itself and its people. It's historical trauma that just is perpetuated. But I think think a lot of the lessons we learn in South Africa are similar to those of the rest of Africa. Who was I speaking? My brain over the past, I'm sorry, I'm a bit jet lagged. Well, went to the Broad. I went to the Broad. I went to the Broad the other day, as one does. Why do you call it the Broad and not Broad? Someone tell me the answer to that. But anyway, it's okay. Anyway, so I went to the Broad, and they've done a number of studies across Africa on trauma. They found that across multiple countries, I think like 8 countries, we're talking about 100,000 people, thereabout. 90% of the people they interviewed had at least one trauma. And I mean, like, you know, my cat died. I mean, we're talking about serious trauma. 90%. You know, this is a continent of colonialism, of refugees, of war. It's income inequality, all kinds of things. So it's not surprising. So the Cape Town's challenges may be extreme, but I think there's lessons to be learned for a lot of Africa from there. So having said that, we have one of the highest murder rates in the world, but again, it's very nicely concentrated. It's not in my area, but you know, that's how it goes with income inequality. It's not in the high income areas. Domestic violence is high, trauma, PTSD, other mental health issues that go with an exposure to violence. General crime outside of murder is extremely high. Robbery, assault, and burglary, much higher than the national average. And like I think this greater area, methamphetamine, which we locally call tick, because they historically would put them in little glass bulbs. The tick and light the bottom of the bulb, and it would make this noise like tick, 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 as the smoke would come up and you'd sniff it. Heroin, dirty heroin, alcohol. Western Cape has the highest rates of substance abuse treatment admissions in South Africa. Gangsterism is high. So just in our city alone, there's 100,000 gang members, and about 130 gangs that control construction, shops. You know, it's like a little mafia type of thing in the area. Internal migration is huge. People migrate for the mundane reasons that all of us migrate, you know, for economic opportunities, education. And so the informal settlements are growing, and partly because of the high cost of living and housing shortages. And then there's refugees and asylum seekers from all of Africa. With all of South Africa's problems, it's still the wealthiest country on the continent. And so this can cause a significant strain on public services and exacerbate social tensions. There's a lot of xenophobia. And as you've seen earlier, the risk of migration, the link between migration and schizophrenia is a significant one. About half the migration on the African continent happens internally. And do you know how many studies there have been on migration and schizophrenia on the continent? 0, not 1, not 1. So this is a good friend of mine, Laila, and she is the first Black full professor in the Department of Medicine at Cambridge University. And she is originally from Nigeria and did a PhD and a lot of other work in South Africa. And she did a fantastic study that looked at kind of a spatial analysis of prevalence, multimorbidity, and its association with socioeconomic disadvantages in South Africa. And so people, so this is one of the things I'd like to challenge, and which you obviously know, but I just kind of want to hit home with it, is that the healthcare problems in Africa are not easily solvable. So people have this idea that if you could just get primary health clinics all over the continent, the problems would be solved. But the greater the income disadvantages, the more complex your problems are, you're going to have early childhood infections. On top of that, you probably were exposed to obstetric difficulties, maybe low vaccine rates, trauma. These are layers. So by the time somebody comes to you with HIV, the story behind it is a complex one. That makes sense. The person who comes to you with cardiovascular disease comes to you with a long story behind it and a social support system that have their own stories around them. And I think it's worth considering. So the urban areas show really high rates of hypertension in South Africa and multimorbidity, so infectious and non-infectious and non-communicable diseases. And a lot of these lifestyle factors that you see so much in America are now being imported into the urban areas across Africa. And that's linked to reduced physical activity, increased stress, and access to cheap processed food, right? Comes with socioeconomic disadvantage. So, you know, the kind of the quadruple burden of disease is that of maternal, newborn, and child health, HIV, AIDS, and tuberculosis, violence and injury, and non-communicable diseases, which is much higher than, and there, including cardiovascular and mental health. So it's like your average patient comes with this risk profile for all of these things, which is complex. So specifically, if we go back to our informal settlements, the association between informal settlements and psychosis is around social adversity, discrimination, marginalization, crime, unemployment, substance use, interpersonal violence, social fragmentation. Very often ethnic minorities live there, rural, urban migrants, and then the influence of social defeat. You come there, you come into urban environment, hoping for a wonderful world, and then you live in that. Right? Health and service delivery inequities. So my take-home messages. Firstly, to remember, urban environments significantly increase the risk of psychosis. If there's one thing you remember, if there's one thing you remember to be that one. But urbanization is likely a proxy. It's not urbanization, it's not like the city is the problem. It's a proxy for underlying social adversities, right? And schizophrenia. And these social adversities underneath it all include factors such as trauma, discrimination, low ethnic density, poor access to green space, and all contribute to the risk. And African cities face additional challenges: the rapidness of the urbanization, multimorbidity, socioeconomic disparities, and inadequate mental health infrastructure. So I just want to say thank you to the wonderful BUMC team, Dave, Maria, Christina, Ashna. Thank you so much for inviting me and for welcoming me to the space this week. It's just been fantastic. And the people here have been wonderful. It's been such an honor and a privilege to be here. Thank you for letting me sit in clinics, in meetings. Yeah, you have a wonderful service and really good people. Thank you.
Thank you so much. That was very fantastic. And it's so much, I think, reflecting too on our own population. We'll take some questions. I'm just going to adjust the share for everyone. If you're joining us virtually and have a question, feel free to unmute, turn on your camera. If you're in the room, just speak loudly. We'll try to repeat the questions so those online can hear as well.
Thank you so much. That was really impactful to sit here and listen to. And I think what Maria said reflected a lot also of the patients that we served as well. So if you think about like the lifespan of psychosis and schizophrenia, like you mentioned, like by the time the onset of like frank psychotic symptoms have occurred, the disease process has been happening for years and compounded by environmental factors. So, you know, something that I think we think about a lot, like where does intervention start? And I guess intervention and prevention too, especially given the environment that our individuals are raised in, like what should we start like prior to the onset of psychotic symptoms, and what is that intervention looks like? Because by the time we're seeing individuals, you know, they've already had all of these insults. Should we be screening for more risks earlier and targeted to certain subgroups of individuals? What do you think?
Sure, that's a great question. So hard. By great, I mean hard. So I think I think the world of clinical high risk is an interesting one. There's many ways to interpret that statement that I just said. But I think that the way, and I think this is how it's moving for a lot of people in clinicians who look at those who are at risk of psychosis, or clinical high risk, or people who have psychotic-like experiences. Clinical high risk for psychosis isn't just clinical high risk of psychosis. If somebody has a psychotic-like experience or psychotic symptoms in their adolescence, only a minority, this is clear, only a minority end up with psychosis. But the rest of them are not exactly like, oh, I've recovered and my life is now swimming. It's anxiety disorders, substance use, depression, and I think mood disorders is all of that. So obviously there's a primary prevention, childhood trauma, and maternal infections and all of that. And I think that's not really what we're looking at. It's that cohort with psychotic-like experiences, or who we call clinical high risk. I think this is happening. There needs to be this broader acceptance that we can't see them in the psychotic silo that we have. It's not about risperidone clinical trials. These are at risk, and we need to support them through different interventions.
So with such a large population that are living in these informal settlements, to what is the extent that mental health services are able to be given to folks that are living in these areas and farther away from the city, maybe don't have resources to get to a health center? So that's kind of what I'm thinking about. And I'm also thinking about with your green space as a potential intervention. I think it's a fantastic idea. And I also just am recognizing the state of some of these areas. Soil quality might not be great. They might be living in flood zones where it's just really not easy to grow anything that's going to stay around for a long period of time.
I think there's a few, and that's a great question. Firstly, when it comes to clinical care, most of these areas, but I think certainly in the urban areas, we've got community clinics that are close by. I don't think integration of services works that well for psychosis. I think our psychiatry nurses who've been doing psychosis work for decades are the best people to manage things. And if you integrate that into general medical care without addressing all the other things that have stigma and all of that, our patients slip through the cracks. So right now, I think psychiatry nurses at community clinics do the best job. We don't have much rehabilitation services, step-down services, so patients end up going to hospitals and the waiting lists are long, and they end up at medical hospitals where the care is often terrible, not intentionally. So there's that. The idea of green space is a very complicated one. I didn't manage to take a picture, but I had to drive alongside a township near the airport, which anybody coming into Cape Town will see that huge township near the airport. And if you look down at that township and you look down at the green spaces, because there's parks, it will glitter from broken bottles. Because that's where people go and hang out and have a good time. So that's not a healthy green space. Kids just don't go there. So it's an interesting take. And then if there's areas for people to, and it's not necessarily a safe space either, in terms of, you know, violence. So you often find kids playing soccer, football, what do you call it here? Soccer. Yeah, next to the highway on a little bit of a patch of grass there, because it's not safe from cars, but it's safe from things happening to them, and it's kind of protected. So that's where people play. So, and any other spaces like the floodplain just gets used. Yeah. And when it comes to growing things, again, it's so complicated that when a lot of people are rural to urban migrants, and I don't ever come to the urban area to grow food. We've come here for a better life and to eat this urban food and to get on with things. So some food gardens have worked, but some there's just no uptake for it. That's not why we migrated, which is interesting. So I think this cultural kind of understanding that needs to happen around them.
Thank you so much. I think just to add on to your point about cultural understanding, something that always stands out for me is what lens are we viewing symptoms and defining it as psychotic, right? I think you mentioned earlier in terms of when folks are within their own social, like racial, ethnic, cultural group, the risk of developing psychosis is much less than if they're marginalized and sort of like isolated. And so I'm sort of thinking about like how do we take this knowledge that like you're sharing with us, finance PMC, when we have a ton of folks who are here for a number of different reasons, and let's say they're concerned about the police, right, or concerned about people watching them and tracking them. If we label that as like paranoia, are we increasing their risk factor going on to developing these psychotic like experiences, right, that further can exacerbate their developmental vulnerabilities that they have?
Yeah, you're absolutely right. And there are plenty of psychotic experiences that within the spectrum of healthy human experience, but 14% people have hallucinations at some point, and not just when they've had a big night out. You know, when you think about things like witchcraft, and it's you know, maybe I should rephrase things, that psychotic-like experiences, not necessarily, they're not pathological, and they don't have to be. But when it's partnered with a functional shift and with distress and with marginalization and with slipping grades, and with difficulties with employment, and with social isolation. And I think that's where community empowerment, and is where you need to link with the community so that people are able to say, actually, I'm worried about my son here because I recognize this as being different from what is healthy in my community. And I think maybe he should see a social worker or whatever. So I think that again, it's like, it's a really important point. It's not about focusing on the individual, and it's about, and pathologizing it. It's about inclusiveness of the community and understanding where they come from culturally as well.
I was thinking a little bit about Dr. Brown's question about prevention. It seems like when you bring up the socioeconomic, the social, and the environmental, you kind of like, it seems to me like you're kind of saying like the domain of prevention is the economic. is the socioeconomic.
Yeah.
And it seems like BMC, we have somewhat of a sense about that, so we can talk about social determinants of health.
Yeah.
But I'm wondering, do you feel like, it would be advantageous, working about prevention for professionals, medical professionals, doctors, clinicians, to understand themselves as, perhaps engaging in like local politics or local efforts that would change the socioeconomic. Because we receive people on the factory line, they come to us and we fix them, but we don't change the conditions that bring people to us. So it seems like this idea of prevention can scale out and out and out. And if we are to like kind of change these things that we're saying are bringing people to us, it seems like at some point you can say, yeah, how do we change this? Is that our job?
Oh. Seems a big field, maybe it's someone's job and that's a public health specialist. Yeah, I think we need to ideally no surveys without service. I think that's important. So when we do research, we need to be very clear around what our service is. And I think the next step would be around what's the supply chain, no surveys without policy. So we really should be doing more research that brings that triangle together. Policy, research, clinical care. And with clinical care, we need to bring in the lived experience. I don't necessarily think that it's our job, but it is our job to advocate policymakers. As much as it is, we need to integrate them better in what we do and in our research. We ask the questions that we think are interesting, either as scientists or as clinicians. How often do we ask the questions around what is relevant to the policymakers? And I think that that's super important. And I can just say from my perspective, like, I hate these politicians. I don't want them on my research team or my advisory board. And so I don't even start the process. But I mean, that's a long-term engagement that we should be thinking about.
And thank you so much. It was very comfortable talk, and I'm just thinking about it's such a complex issue because there's the stress and the trauma related to migration, but there's also the person's comment, the political climate and the inclusiveness and just your talk, like the socioeconomic inequality. Like just thinking about Boston or Beaconville and Roxbury with a 20-year difference in life expectancy. Just as a researcher, I'm just sitting with all these thoughts, and I'm interested in your thoughts on like how can we best capture all these very complicated social issues in our research and include like political. I almost want to control for like political climate, for example, but I don't know.
Oh, I think it's so hard. It's so hard because we're dealing with a very complex condition. And before you know it, you're doing 3-hour assessments with patients to try and get all the data. But I do think there's something linking to the previous question. I think there's something to be said for being very thoughtful about what outcomes we measure. And I think we need to be more thoughtful about patient-related outcomes. So what's important to patients? I know that is pathways to care and transportation and their livelihood. We need to be looking at that, but we need to be asking that question. And if that's more important than full PANS and we need to do an abbreviated thing, well, then that's what we've got to do. Or at least think about it. We should, I mean, that should be the starting point of a lot of our research. And I'm saying this like it's a fact, and I can only aspire to do that, but I think that that's the way it's going. Should be going.
Real quick, we're almost at time, but someone had a question on Zoom. Someone had a question on Zoom.
Oh, Wanda, urban gardens in Cape. Would these work, giving family seedlings? I think Bonga, I tried growing vegetables during COVID and it costs approximately $100 per aubergine for it to survive, or $100 per eggplant. It's so hard to get these things to grow, man. Maybe, you know, I think that one answer would be yes, but I think we need to be, again, very thoughtful around how we do it and the sustainability of these things. It could work. It could work, but it needs to be done in a thoughtful way and not just giving trays to people in townships. And I don't think that that's what you had in mind at all, Bonga. But I think that somebody who's doing it needs to do it. And there have been people who've done it. And when it's done thoughtfully and well, and there's huge urban gardens in townships like Philippi, where there is actually green space, and that's worked very well. There has to be linked to money. People will do it in goodness own. Goodness of my heart when I can't school my kids. And you know, getting money from lettuce is not easy. Feeding yourself with lettuce is not easy. So you know, there's all these things that you need to think about. Thank you, thank you. Yes.